We do have a couple questions that came in. So Melanie would like to know, when doing deep flap reconstruction, how do you minimize the Frankenstein, in quotes, look and other less appealing outcomes as a result of the operation? And she also mentioned dog ears.
Okay, well, that's great. I think the most Frankenstein, if we're referring to Frankenstein as being visible scars, for example, across the front of the breast, that's going to be common if someone goes flat and then has a breast built later. It's inevitable that there will be a long scar across the front of the breast. Otherwise, avoiding the visible scars on the front of the breast generally is part of the plan between the breast cancer surgeon and the plastic surgeon. The breast cancer surgeons who only will do surgery with a large transverse incision aren't common in Austin. Most of the breast cancer surgeons that we work with have the skill to create a hidden incision in conjunction with the plan with the plastic surgeon. Dr. Bunting, can you talk to us about the scar planning for mastectomy?
Yeah, so I think it all comes down to the planning, both for the belly and for the breasts. Planning a low incision on the abdomen as low as you can is nice, trying to minimize dog ears from the get-go so that you don't have those later on. And then in terms of the breast, so going through the inframammary fold in a nipple-sparing mastectomy gives a beautiful result. And then just planning exactly what is needed based on what's done with the cancer surgeon. So around the areola or exactly what can be done.
And our team of plastic surgeons is very sensitive to aesthetic planning, both in the planning of the mastectomy and in the location of the deep flap abdomen scar. And I think it's worth taking the extra time to take off those corners at the time of the initial surgery. But Dr. Honore, could you talk to us about the location of the blood vessels for the deep flap surgery and how that impacts the location of the abdominal scar?
So the deep flap surgery is about defining a soft tissue block, basically what would typically be removed for a tummy tuck, and tracing the blood vessels that feed it, which travel through the muscle, the six-packed muscles coming up and down, opening the encasements of that muscle, and then tracing the blood vessel from where it's coming out to feed that soft tissue block through that muscle tract and then off a major blood vessel in the groin. The blood vessels that feed what's left behind for wound healing come through other perforations coming up through vasculature within muscles of the abdominal wall that when you're doing your harvest for the flap and elevating tissue like you do with a tummy tuck. Because with a tummy tuck, which is essentially the same foundation for the deep in terms of the soft tissue definition, to close it, you have to elevate high in order to mobilize that tissue so that you can pull it down. And so it's about knowing where the blood vessels that remain are coming through, and that's over the rib cage. So sort of staying in the area that preserves those remaining blood vessels that are important for nourishing the wound healing part of the procedure.
So the CT scan locates the main blood vessel that feeds the tummy, but if the main blood vessel is a little higher than the belly button, my experience is that we end up needing a little bit of a higher scar, but for most patients that we take care of who have when they have the typical anatomy, with a little extra time in the dissection, we're able to plan a lower scar. Technically, it's easier to go fast if you dissect a high flap and you end up with a high scar, which I think using the term Frankenstein, or sometimes I've called it the Humphrey Bogart scar. It looks like those high-waisted pants, very high scars. High scars come with high perforators, but if you plan your dissection low, you can get a lower scar in a lot of patients, right?
And I was thinking also with the Frankenstein comment of the breasts, and it does go back to where the skin paddle is. The skin paddle is a common term we use for the skin remnant of the flap that's going to be visible on the chest. Sometimes it takes extra steps to ensure that, like a tissue expander, which would be a space holder to create a natural breast envelope and sort of allow there to be a continuity between your neck, upper chest, breast mound, and your belly skin, as opposed to bringing a large chunk of skin from here because you need that surface area from somewhere. So that first step is, for example, if someone shows up with flat reconstruction or just no reconstruction with a big incision, it would be, if that's very important to you, putting a tissue expander first and maximizing that surface area so that we have something to put the flap into that allows the hiding of that flap skin. You don't need it as much. You just will have your own. So pre-planning in terms of the surgical technique, but also the stages and steps of surgery help with that and are important to all of us. I think we all marry both our cosmetic and reconstructive practice. Like, we all love talking about ways in which we can render a cosmetic result. And there are so many ways to do it, so many combinations of ways to do it.
And that's really important to all of us. We all share that. Patient satisfaction and happiness for sure is associated with symmetry and longevity of result, minimizing revisions, but also hidden scars.